Good morning. We are going to talk about the peripheral intravenous cannula. Could you describe the structure of a standard cannula?
Good morning. A modern peripheral cannula is an over-the-needle device with 5 components. An outer plastic cannula that remains in the vein, an inner metal stylet that protrudes beyond the cannula tip, a flashback chamber at the proximal end of the stylet, a hub with an injection port, and wings or flanges for stabilization and fixation.
What material and why?
Modern cannulae are made of polyurethane or Vialon, a proprietary polyurethane derivative. These materials soften at body temperature, which improves comfort and reduces vein irritation. They have a lower coefficient of friction than the older PTFE, Teflon, and are less thrombogenic, reducing phlebitis.
Take me through the color code.
Internationally standardized under ISO 10555. Yellow is 24 gauge, blue is 22, pink is 20, green is 18, grey is 16 and orange is 14. Approximate gravity flow rates: 24 gauge 22 milliliters per minute, 22 36 20 61, 18 96, 16 196, 14 343.
Why is the increase non-linear? What law governs it?
Flow is governed by the Hardgen-Poiseuille equation, which applies to laminar flow of a Newtonian fluid through a rigid tube. Flow equals pi multiplied by the pressure gradient multiplied by the radius to the 4th power, divided by 8 times the viscosity multiplied by the length. 3 clinical implications. Flow is proportional to the 4th power of the radius. Doubling the radius increases flow 16-fold. Flow is inversely proportional to length, and flow is inversely proportional to viscosity, which is why blood flows more slowly than crystalloid.
Apply that. Why is a 16-gauge peripheral cannula not the same as a 16-gauge central line for resuscitation?
Length. A peripheral 16-gauge is about 45 millimeters. A central catheter of the same bore is 15 to 20 centimeters, 3 to 4 times longer. By Poiseuille, flow through the central line is 1/3 to 1/4 of the peripheral. For rapid resuscitation, 2 large bore short peripheral cannulae will outflow a multi-lumen central line every time.
When does Poiseuille no longer apply?
When flow becomes turbulent, at a Reynolds number above approximately 2000. Once turbulent, flow becomes proportional to the square root of the pressure gradient rather than linear with it, which is why doubling the bag pressure on a pressurized infuser does not double the flow rate.
How do you choose a cannula size?
By indication and vein available. For day case surgery, a 20-gauge pink. For most adult general anesthesia, an 18-gauge green is the workhorse. For anticipated major hemorrhage or trauma resuscitation, at least one 16-gauge grey, ideally 2 large bore. For pediatrics, 22 or 24. And in elderly patients with fragile veins, a smaller cannula in a good vein is more reliable than a larger one in a marginal vein.
And the site?
I consider vein quality, patient comfort, surgical access, the planned use and patient factors, avoiding mastectomy side, fistulae, hemiplegic limbs or limbs with lymphedema. My first-line choice is the cephalic or basilic vein of the non-dominant forearm. The dorsal venous network is acceptable but uncomfortable. Antecubital fossa veins are large and useful in emergencies, but flexion can occlude the cannula.
Walk me through your technique.
Using aseptic non-touch technique. Preparation, confirm identity, explain consent, check allergies, particularly chlorhexidine, latex and adhesives. Assemble equipment on a clean tray. Vein selection. Tourniquet 8 to 10 cm proximal, tight enough to impede venous return but not arterial inflow. Allow the veins to engorge. A palpable bouncing vein is preferable to one that is merely visible. Asepsis. Decontaminate hands, apply non-sterile gloves, clean the skin with 2% chlorhexidine in 70% alcohol for 30 seconds, and allow 30 seconds to dry, do not blow or wipe, as that abolishes the antiseptic effect.
And the puncture itself?
Anchor the vein with distal traction of the non-dominant thumb. Hold the cannula bevel up, approach at 10 to 30 degrees, and advance until flashback appears in the chamber. At this point, the stylet tip is in the vein but the plastic cannula is not yet. It sits a few millimeters behind. Lower the angle, advance the whole device a further 2 to 3 millimeters. Then, holding the stylet still, advance the cannula off the stylet to the hub. Release the tourniquet, apply digital pressure proximal to the cannula tip, withdraw the stylet directly into a sharps bin. Attach a primed extension or bionector. Flush with 5 to 10 milliliters of saline to confirm patency and absence of swelling. Dress with a transparent semi-permeable dressing, and document.
What is the secondary flashback?
A second small flashback of blood that tracks between the stylet and the cannula, and is visible at the hub. It confirms that the plastic cannula, not just the stylet, has entered the lumen, and is the cue to safely advance the cannula off the needle. Watching for it reduces extraluminal deployment.
If you don't get flashback,
Pause, withdraw slightly without leaving the skin, repalpate, adjust angle, re-advance. NICE and Royal College guidance is a maximum of 2 attempts per practitioner before escalation to a more experienced colleague or to ultrasound guidance.
tell me briefly about ultrasound-guided cannulation.
A high-frequency linear probe, 7 to 15 MHz in short or long axis, indicated for the patient with non-palpable veins, obesity, chronic illness, intravenous drug use, pediatric difficult access, or repeated failed conventional attempts. Evidence supports higher first-pass success and fewer attempts. A practical point: use a longer cannula, 48 to 64 mm, because deeper veins need more length to retain a stable intravenous segment.
Complications, take me through them.
3 categories: immediate, failed cannulation, hematoma, pain, nerve injury, air embolism, and operator needle stick. Early, extravasation, infiltration, phlebitis, mechanical, chemical, or infective, thrombophlebitis and occlusion. Late, catheter-related bloodstream infection, venous thrombosis, persistent pain or nerve dysfunction, and rarely retained cannula fragments.
Define extravasation and infiltration.
Infiltration is the inadvertent administration of a non-vesicant into the surrounding tissue. Extravasation is the inadvertent administration of a vesicant, a drug that causes blistering or necrosis, into the tissue. Vesicants the anesthetist must remember: vasopressors, noradrenaline, adrenaline, phenylephrine. Concentrated electrolytes, potassium chloride, calcium chloride, high osmolality contrast, and hypertonic dextrose or parenteral nutrition.
What do you do for extravasation?
Stop the infusion. Disconnect the giving set but leave the cannula in situ and aspirate as much of the drug as possible through it. Mark and elevate the limb. Assess for compartment syndrome. Specific antidotes: phentolamine infiltrated locally for vasopressor extravasation, hyaluronidase for some non-vasopressor agents. Escalate, involve plastic surgery early for any vesicant injury. Document and submit an incident report.
Phlebitis types.
3. Mechanical, large cannula in a small vein, movement, prolonged dwell. Chemical, high or low pH, high osmolality, known vein irritants such as potassium, amiodarone, vancomycin. Infective microbial contamination at insertion. Graded by the visual infusion phlebitis score. A score of 2 or above means remove the cannula.
How do you minimize catheter-related bloodstream infection?
EPIC and NICE guidance plus ONTT. At insertion: hand decontamination, 2% chlorhexidine in 70% alcohol with 30-second contact and drying, clean gloves, no repalpation of the prepared site, transparent dressing. During use, scrub the hub for 15 seconds before every access, flush with saline, minimize disconnections. Review daily using the VIP score and remove the cannula as soon as it is not needed. Current evidence supports clinically indicated replacement rather than routine 72-hourly.
Cannulae inserted in emergency conditions.
Document the breach in asepsis at the time and replace electively within 24 to 48 hours under controlled conditions. Reflected in EPIC3 and NICEQS61.
A short scenario: obese 70-year-old man, emergency laparotomy, no visible or palpable veins. Walk me through access in the next 10 minutes.
A staged escalation. 1. Optimize conventional access. Warm the limbs, tourniquet, palpate the cubital foci and cephalic vein at the wrist. 1 reasonable attempt by an experienced operator. 2. Ultrasound-guided peripheral access with a long cannula, targeting the deep brachial or basilic veins. 3. If access fails or large bore is needed urgently. Intraosseous, humeral head or proximal tibia. flows up to 150 milliliters per minute under pressure, and is reliable in the shocked patient. 4. Central venous access under ultrasound, once the patient is induced and stable. In parallel, do not delay the case for perfect access. Proceed with what you have, upgrade intraoperatively.
Why is intraosseous useful?
Because the medullary cavity is a non-collapsible venous plexus draining centrally. It can be established in 30 to 90 seconds, delivers any drug or fluid that can be given intravenously, and flows reliably in the patient with collapsed peripheral veins. Endorsed by Resuscitation Council guidelines for emergency vascular access when peripheral cannulation fails.
Final question, 5 take-home messages.
1. Match the cannula to the indication. Pink for day case, green for routine anesthesia, 2 large bore, grey or orange for resuscitation. 2. Remember PWASOI. Flow rises with the fourth power of radius and falls with length, short and wide beats long and narrow for rapid infusion. 3. Use a NTT every time. 2% chlorhexidine in 70% alcohol, 30 seconds contact, 30 seconds drying, no repalpation. 4. Recognize extravasation early. Stop, aspirate through the cannula, mark and elevate, escalate for vesicants. 5. Review daily and remove when not needed. VIP score, clinically indicated replacement, not routine 72 hourly.
Thank you, that concludes this station.